Now, we all actually manage this situation, hypermature, suprahard cataracts, and we all have been doing it day in and day out. I'll just kind of highlight the situations which we really face and how I would like to tackle them. So basically, the principles. Firstly, the principles of management. We need a very good viscoelastic device, and we need to choose a viscoelastic device like according to the step we are managing. Uh, Another principle is, we need to manage the pupil beforehand, because these super hard cataracts very often present with small pupils or floppy iris syndromes. So we need to manage that, because that is the first thing we need to check. Unless we have a adequate pupillary dilatation, the whole surgery becomes difficult. And the third thing is the capsule management. We need to manage the capsule well. The capsular axis itself, it's a very important part of the whole surgery. Unless that is well done, rest of the difficult surgery would be more difficult to handle. And then is the nucleus management for the suprahard cataracts. I'll start with the first video where as you can see, without a variant, I externally I mark the rhexis size, because we need a very adequate rhexis. And after staining the capsule with trypan blue, you can use any instrument, a cystitome to start with, and then I use macro rhexis forceps. But it is upon, it depends on the surgeon. It would vary with surgeon to surgeon. Anyone can use any instrument, and whatever is suitable. But yes, a good viscoelastic is required so that we have very good tamponade, and this rhexis becomes easy. And we need to remember that an adequate size of rhexis, a large good rhexis, is required. Now, a gentle hydrodissection. Many times we may not need it, but mostly it is good to do a gentle hydrodissection. And then what I generally do is I make multiple cracks from the periphery. These cataracts, it's difficult to reach the central posterior plate at one go. So once I do multiple cracks from the periphery, the central amorphous hard part of the nucleus is it's delineated, and this is the hardest core of the nucleus, and this can be emulsified to make space within the center of the nucleus, which really helps when we separate each piece and when we try to extend the cracks to the center of to extend to the center plate, the hardest center plate. Now, for this we need many techniques. Sometimes we do multi-level chopping. Once chopped, we go deep inside and then chop again, so that the separation is well done and each piece is separated. And then we take one by one, emulsify them, and then we go ahead for implantation of the IOL. So these are the basic principles that we need to use in these kind of cases. Now, this is a situation where it's very often found that very calcified, thickly calcified anterior capsule. Now, this calcified anterior capsule is really very difficult to manage. At times we have to cut it with the small, this cystitome, but it needs to be a controlled cut. And many a times even this cystitome cannot cut the whole calcified tissue. You can see I am struggling with these hard calcified areas, and you cannot do much. This is where I use a angled micro scissor. I have been trying with the cystitome, nothing is happening. So I am using this angled micro scissors, and we cut it. You can literally cut it so that it becomes easy for us to continue doing the rhexis. So this is how, special situations need special devices. You need to cut them open with micro scissors, and then you can continue with the rhexis. And maybe at times you use the rhexis forceps to make a controlled pull. Once this is done, once the rhexis is done, we know the strength of this rhexis is not as good as our normal continuous curvilinear rhexis. So we need to be very careful when we crack these nucleus. Not much of lateral separation can be done, so we need to be careful in these situations. Now, this is another situation where you can see it's kind of intermission, and after we need to stain all these capsules because otherwise it becomes difficult. And we start with a small rhexis and enlarge it slightly bigger with a macrorhexis forceps. This is the standard Haldipurkar rhexis forceps, macrorhexis forceps, where you can really have a good control to enlarge the rhexis. So this and rest of the situation is fine. This is a special situation where again the whole cortex is liquefied and there is a central hard nucleus which is floating inside. Now rhexis itself, it becomes difficult, but after staining, here again we start with a smaller rhexis. I'm using a rhexis forceps and a smaller rhexis to go with, and then as you can see, I'm slightly enlarging, and here also there are calcifications in the anterior capsule, and gradually I make it a bigger rhexis. Now the problem with this cataract is not just the rhexis. Rhexis is one problem, but here as you can see, when I try to impale the nucleus at the center for chopping, the nucleus would start rotating. And it's very wobbly, and as you can see, it will start rotating and it's very wobbly. You really can't fix it. So once, and see it's rotating. So unless you can fix this nucleus, you cannot crack. It's very mobile. So at some point of time, we need to fix it first and then impale it in the center, which is really difficult. But once we can do that, we can create a crack. The first crack is important and rest would follow. So that is the biggest challenge. We need to impale it in the center, fix it and impale it in the center. Right. Now, this is the last situation I would like to discuss. Here again, what we can see is it looks like we can manage with this size of the pupil, but it's a hard cataract. But once I, stain, the pupil size becomes smaller because of the turbulence of the BSS. And yes, here I would like to use a Malugin ring or any pupil expansion device, and so that it becomes easy, the next steps becomes easy. That is all. Sometimes we do use iris hooks whenever the pupil is very rigid. So I'll, because of lack of time, I'll curtail this part. Thank you so much. If you have any,
switch off the light altogether, because nothing is visible. It's
Sir,
I know.
sir, it's not possible because all the auditoriums are.
not about dimming, about switching it off.
You cannot do it because you can switch off all the auditoriums at a time, not individual
Because
auditoriums.
this is a surgical based session. It's absolutely useless showing this video.
I agree with you, sir. I agree with you. भैया, can we ये no, एक मिनट, ये टीवी है, वो पब्लिक की ओर कर सकते हो प्लीज, उसका फेस वो बाजू कर सकते हो, प्लीज डू इट.
टीवी को ऊपर लाके
एक मिनट.
Yeah. And as chairperson, you can come and sit here.
Chairperson can sit anywhere, no problem. वो छोटा हो जाएगा, ये उठा के पूरा इधर बाहर.
There's no point doing FACO here. So SICS has been planned, and we'll go a little fast. And you can see here, before that I do little, once I complete the wound, I make a side port, and then of course we go ahead to tackle the vitreous first. We do a vitrectomy, anti-vitrectomy, and then we, with a Vervectis, we take the lens out, and as you can see, it needs to be taken out in toto. It's more or less a clear lens, and once that is done, what we see here is a small iododialysis at the 6 o'clock. Now this is yet another extreme situation. Whole bag with the nucleus is there in the AC, and it's a spontaneous dislocation, and it's not a traumatic one. So these all are possible. Now in all these cases, when it's already there in the AC, we take out with an Vervectis, and For the IOL selection, we used to do, there are a lot of ways now. What we do here is glued IOL, and a glued IOL, but we need to understand, we need to do a very good vitrectomy whenever we are going posteriorly, and this is how it is done. There are multiple methods of doing it. Pulling out the leading haptic first with the macroforceps, and then taking the other haptic out through the other under the other flap. The flap are pre-designed, and of course there are small preformed channels there which where the haptics are tucked, and sometimes we use a AC maintainer to keep the AC formed while we implant the lens and take out the haptics. And then the rest is like we use fibrin glue, or we use glue to after tucking the haptics, we use glue to fix the flaps and the conjunctiva as well. Now this is how it is done. Well, this is another case where we these retrofixation of iris claw lens is also being used now very commonly. These are handy, except for in trauma, where trauma has badly damaged the iris or the pupil. We don't use them. Otherwise, we can always use them. It's easy, simple method, but vitrectomy has to be done, and then the pupils are to be people should be tucked into the claws. So this is how it is done. It's simple. Now this is another situation where you can see there is a small subluxation. It's visible, but there was no vitreous. So sorry. So what we did, I started doing after a good rhexis, I did a little hydro dissection, and then I thought we should put a CTR beforehand, but it would have been done the other way around as well after the cataract removal. But unfortunately, all this has it has added to the trauma, and there was vitreous in the AC. Even without staining, it was very much visible. So anti-vitrectomy was done, and once the vitreous settled, normal phacoemulsification, a slow motion phacoemulsification is done, and of course lens is implanted. This is another short video I would like to show, because here you can see this is a traumatic subluxation, a young man, and after doing an adequate size rhexis, what we do is a normal hydro procedure. I'll skip these steps. After removing the nucleus, a soft nucleus, I implant a capsule tension ring, where and then after putting the lens, I check with little triamcinolone acetate, and with triamcinolone the vitreous is stained, and once vitrectomy is done, anti-vitrectomy is done, we feel that we are secured. But after the pupil is made small with pilocarpine, we see still vitreous is peeping out. So that is where we go from behind, so through the pars plana, and then everything is cleared. So it is always better to go from pars plana to do a vitrectomy in these situations, because even if we think that everything is fine, at the end of the surgery, some vitreous may just come out through the pupil. It can peak the pupil, cause traction, and later retinal detachment. So it is better to go through the pars plana route and clear up the vitreous there. Thank you. Okay, this was another extreme situation, but because of crunch of time, I'll not go into it. But we need to, all these situations, we need to plan beforehand. And here again, what we do is we do vitrectomy, lensectomy, and iris, scleral fixation of IOL. Not exactly, it's a glued fixation, and glued IOL fixation, and then repair of the iododialysis, which was a huge iododialysis there, right? So thank you so much.
If you are doing the operation under topical,
yeah,
and you need to do pars plana,
yes,
do you give a subtenon block?
Yeah, subtenon block can be given, and it's best to give a subtenon block, because patient did not expect all this, and there could be a lot of pain. But many situations, if the patient, you have to judge because this particular case I showed was a young man, and he has tolerated on topical. It was a 27 gauge, vitrectomy, so he tolerated it very well. In fact, he didn't feel, he did not complain. Right.
Thank you.
Thank you so much.
Thank you so much, Dr.